Good evening, friends. Welcome to this Tuesday evening masterclass sessions. In collaboration with the ISCM Hyderabad chapter and Yashoda Group of Organization from the Department of Critical Care Medicine, we have been bringing this masterclasses for the postgraduate students on the all categories from the DNB, DM, and all the ISCM courses. So we have been covering all the commonly cases in the exam pattern, and we always invite two students to present the real-time case scenarios. And today we have Dr. Vignesh and Dr. Karthik, who will be presenting a case on acute coronary syndrome. And will for these two cases, so we have two seasoned examiners and faculty for the both National Board and ISCM. Dr. Chandana heads the unit of critical care department in Star Hospital, Hyderabad. Welcome you, ma'am. It's always
Thank you.
glad and a pleasure to have you, ma'am. And we have other examiner and faculty, Dr. Madhusudan Jaju, who is a HOD and Director of Critical Care Medicine from the KIMS High-Tech City, Gachibowli. It was earlier a part of the Sunshine. Now it is a KIMS Gachibowli. Dr. Madhusudan Jaju, welcome on board.
Thank you, Venkat.
I invite both the examiners to request the students, Vignesh and Karthik, to start the presentation. And this will be like, ma'am, on board real-time bedside exam. So we can actually stop the students from the initial first slide of examination or the history, and we can take them to the different differentials like what we do in a real-time bedside examination, ma'am. It's not like the preformed set of questions or something. And we also will go through the questions from the chat box, ma'am, and we'll try to answer them all together.
Okay, fine. Yeah.
Okay. Vignesh, over to you. Vignesh, are you there? Chandana, ma'am, light is on the back of you.
Yeah, I'll switch it off for a second.
Better.
Karthik, you can take over. Vignesh has some connectivity issue, I think so.
Karthik, do you have the PPT ready?
Sir, 1 second, sir. New system, sir. Sir, 1 second, sir.
Vignesh is connected, sir.
Yes, sir.
Yeah, please, Vignesh, go ahead and present the case.
Vignesh, unmute yourself.
Vignesh, unmute yourself. Start the slide share.
You're able to see the screen, sir?
Yes.
Yeah, we can see the screen. Go ahead.
The 62 years old female presented with complaints of chest pain for the past 4 hours in the middle of the chest, and it's substernal, and heaviness is present. The pain is radiating to the back and to the left hand. There are no aggravating or relieving factors, or there is no variation with respiration has been seen. It was associated with the breathlessness, which is progressive. Initially, he had an NHI 2 scoring of breathlessness, which is now progressed to grade 3 now. And it is not associated with any palpitations, orthopnea, paroxysmal nocturnal dyspnea, syncope, no history of cough, nausea or vomiting or sweating as such.
Okay, Dr. Vignesh. When a patient comes to you with chest pain, so what are all the things you will consider first? What are all the differential diagnoses you think of first when a patient comes to you with chest pain and then breathlessness also? These two symptoms combination, what are the things you'll consider?
Chest pain with breathlessness, say that it could be cardiac or it should be respiratory, madam. Cardiac wise, it can be an MI. If you think of respiratory, then it can be an.
So complete all the cardiac causes first. Tell me all the cardiac causes first, then go on to the respiratory causes. That way you will not miss anything in the differential diagnosis. Yeah.
Cardiac causes, MI, aortic dissection can be a possibility.
Okay.
And, any stenotic lesions can again present with chest pain and breathlessness. When we look at the respiratory causes, then again pneumonia, pulmonary embolism, any pulmonary edema, acute onset pulmonary edema, those things also can cause breathlessness with chest pain. Then
how do you differentiate between the cardiac and the non-cardiac? What are the typical features of a cardiac chest pain?
Cardiac chest pain generally will be substernal, depicted by this patient. It will be heavy, and there won't be any aggravating, or there can be an aggravating factor in case of an MI, as in with exertion it has increased, and but there won't be any variation with the respiration unless the patient is having associated pericarditis as such. And then associated complaints like
even pericarditis won't change with respiration. Pericarditis won't change with respiration. No, it's not a pleuritic chest pain.
yes,
It won't change with respiration. Yeah. So there won't be any change in movement or respiration. Okay. What else? What are the classic features of cardiac ischemic chest pain?
there won't be any. It will be associated with palpitations generally and breathlessness, and patient will be having sweating also, madam. When the patient is having ischemic chest pain.
Okay. What about any radiation features which will help you diagnose suggestive of coronary ischemia?
Generally radiates to hand. Bilateral hand radiation is actually more typical, in fact, and sometimes can radiate to back of the chest as well.
Jaw also.
In the jaw also. Okay.
Up to jaw level, it can be radiating.
Okay. And what are other features? How do you differentiate from aortic dissection? How do you differentiate cardiac? Because that also can radiate to the back. And you can have sweating, and you can have palpitations, you can have breathlessness, everything can be there with aortic dissection also. So how do you differentiate between aortic dissection and, because it's very important to differentiate between the two.
So patient will be complaining of the worst chest pain ever, and again it will be radiated to back as well. But on examination, if we measure the pulse, then we'll be able to tell whether there is any pulse deficit between both, or decrease in change in the BP between both the limbs is seen. Then that could give us a clue to tell that it's aortic dissection.
Okay, so what are other things which can be seen in the can the coronary pain be seen in the upper abdomen?
Epigastric pain.
Yeah, can it present as epigastric pain? A coronary ischemia can present as epigastric pain?
Yes.
Yes, ma'am.
In which conditions it can happen?
Inferior involvement.
In other ways, what madam want to ask, what are the atypical presentations? What you told about the typical presentations of the acute coronary syndrome, what are the atypical presentations are there?
Atypical presentations may be dyspnea, only dyspnea, presentation with only dyspnea, or sweating, or uneasiness in the body, or impending doom. All these things are atypical presentations of MIs.
So in which group of patients is the atypical presentation more common?
Diabetics.
Diabetic patients predominant.
And females. Females also is more
Female.
common. Females, elderly people, and diabetics. In this group of patients, you can have more atypical presentations compared to the typical intestinal kind of a pain. And even another respiratory condition you should think of is a severe asthma. Sometimes the severe asthma with severe bronchospasm also, they can have a little tightness of the chest and retrosternal tightness with difficulty in breathing. So they can present exactly the same way in an acute exacerbation of asthma. So that also should be an important differential diagnosis. And of course, there is a pneumonia and
PT.
fluid effusions. Okay. So in okay, so what are the conditions with nausea, vomiting? Nausea, vomiting, retching, presenting with chest pain. What are the differential diagnoses you'll think of? This patient who had breathlessness and chest pain, but this patient also had nausea and vomitings, and then has chest pain, retrosternal burning chest pain. What are the differential diagnoses?
Esophageal rupture as well can cause initially the patient with nausea, vomiting, followed by chest pain. That can be a possibility, or a standalone.
More common than esophageal rupture.
Malleary veins.
GRD.
GRD. So GRD is a common thing. You can have esophageal spasm, simple spasm with chest pain, retrosternal chest pain, and they can present with nausea, vomiting because of the reflux GRD. So commonest will be GRD.
Yes.
Okay. Then less commonly you can have esophageal rupture and okay. So in this patient, so how do you now try to differentiate between all these causes of chest pain based on other history? What will you ask for other history apart from the typical type of chest pain? Okay, one thing. Second thing, what are the other history you're going to ask and try to identify whether this patient has more of coronary syndrome or a non-coronary cause of chest pain?
So you asked about cough, associated cough, anything is present or not, to rule out is there any respiratory cause of chest pain, and nausea, vomiting as well. I have ruled out to rule out the gastric or abdominal content which is causing the chest pain.
Okay.
Other than,
What-
I've also asked about if
Fever.
it is a cardiac chest pain. I have asked about orthopnea and paroxysmal nostril dyspnea to rule out failure, and syncope is to rule out any.
What is orthopnea? What do you mean by orthopnea?
So when a patient tends to lie down, the breathlessness actually tend to increase because of the increased venous return to the heart, and heart is not able to handle it. So that's why the patient tend to get up again and will be having a gasping of breath.
So what are the causes?
patient-
What are the other causes of orthopnea? Non-cardiac causes of orthopnea.
Cardiac causes.
In which condition
Any
patients
mass, any
in-
anterior mediastinal mass which is compressing, again it can cause orthopnea. madam.
more common than this, more common than mediastinal mass. Very rarely you see mediastinal masses. No, more common than that. Cause of orthopnea.
Thymoma.
No, they're all mediastinal masses only you're talking about. Non-mediastinal mass, other conditions, more common conditions.
Then goiter.
No, they're all coming in the same category. No, you can talk of anti-mediastinal structure compressing the trachea, causing breathlessness. What are the more common conditions? What about any neuromuscular weakness can cause orthopnea?
No, I'm not aware.
Diaphragmatic weakness or diaphragmatic paralysis is a very common condition where patients have more difficulty in lying down position because of the abnormal position of the diaphragm. They already have weakness and it's more difficult to breathe at that. And anybody with a severe exacerbation of asthma, COPD, they all feel better in sitting up position compared to so any exacerbation of asthma, COPD also they'll have orthopnea. They feel better in the sitting up position. Though the mechanism of orthopnea is different, but they all can have present with orthopnea. Okay, so then go on to the next slide.
Just one thing about Vignesh. When we are talking, always start from the common causes. Always you are talking about esophageal ruptures and other things are there. What are the, always you have to start from the common causes to the rare causes.
Yes.
Once you start about the patient having esophageal rupture and everything is there, is not very common in today's life.
Yes, sir.
Other important thing about the chest pain, it may be a simple muscular pain also, or chondrochondritis also.
Yes, sir.
Okay, that may be also possible thing is there for the patient. And what is the negative history you are going to ask to rule out the things?
Trauma.
Okay, next.
Yes, with the respiration, if it is getting increased or anything, that again can tell us it's a chondritis kind of a chest pain, or the patient is able to touch particular point and tell that is where I'm having chest pain. Again, that can rule out to chondritis.
Okay, so localization is not a very common feature in coronary syndrome because they're not able to localize the pain. It's more of a more diffuse pain and unable to point out to a particular section. Unlike a pleural chest pain or a musculoskeletal pain, they're able to point out more clearly to the site of the pain or location of the pain. That's one feature. What about PT? How will you? What are the things you'll work off? Ask for history for PT, on history to even rule out PT.
Patient, we have a PT, then we have to raise the. Look at the looks factors of PT. Already patient had any previous PT or any history of DVT present. Other than that, previous history of PT or DVT, anything present, and the patient is PT can actually stand
history of malignancy, any history of recent surgery or any recent immobilization for longer duration, and all those things we'll take in the history, ma'am.
Swelling of the feet first. You will ask for unilateral limb swelling. Limb swelling, common is caused by DVT, no locations for the focus of. So you'll ask for history of unilateral limb swelling or any history of bedridden state, prolonged immobilization, dehydration. These are the more common things than malignancy or a past history of DVT, PT. So you'll have to ask for the more common. So always think of the common things first, like Dr. Madhusudan said. You're talking about the rare risk factors. You tell us the more common risk factors like dehydration, bedridden state. Okay, history of unilateral edema, any history of trauma, surgery to the limb, any fractures in a post-op state. Okay, so all these things you have to ask history, and then you can probably rule out a less likely chance of. You can use the scores to identify whether the patient has a low probability or a higher probability of having a DVT PT. Okay, you can do that. Okay, go on next.
Negative history is very important to rule out a rule in or the problem is there, because most of the patients, patients of GRD, patients of heart problems, patients of lung problems, muscular problems, neuromuscular problems, all the patients of choking, diaphragmatic weakness, all will present the same things. So that negative history is very important, and always look for the past records of the patients whenever they're available for the past records for the patient, so that we'll get the clue what is the problem what the patient is suffering from. Please go ahead.
So, no patient is a known case of diabetes for the past 10 years and oral hypoglycemic medications and hypertensive as well. And the patient is on routine follow-up with the physician. Has no other comorbidities.
Okay, let me stop you here. What are the risk factors you want to know for this for a patient who is suspecting acute coronary syndrome based on the history? Now, what are the comorbidities you want to know about, and what are the risk factors you think are responsible for a patient to have ACS?
Diabetes, hypertension, hyperlipidemia, any obesity is present or not, patient history of smoking, any
history.
similar complaints, again, it can tell us. Family history of also has been implicated.
Okay, especially if the patient, the family has got it MI at a younger age. So somebody has the family has MI at 70 years or 80 years, it doesn't become a significant family history. Only if a patient has younger MI in a family, somebody in the family has MI or a coronary artery disease at a young age or premature MI, then you take it as a family, significant family history. Okay, then what is age? What are other risk factors?
Age, in females more than 55 and males more than 45 also has a high risk factor to predispose to MI.
Okay. Okay. Then what is, go ahead. What are the other? Go on with the history.
So patient had no similar complaints in the past, and patient is not on any other medications other than the OHAs and antihypertensives. No history of any addictions.
What are the addictions you're thinking about? What are the addictions you ruled out? You want to rule out?
Only smoking, and if
smoking is one. Okay. What else?
Cocaine abuse also can.
Yeah. So younger patients and especially males, younger patients who are likely to be at drug abusers, then you can ask the history. What is the importance of medication history? What is the importance of medication history? You're asking about medication history. How does it help you?
I want to know whether the patient is already on statins or patient is already on aspirin, because most of the patients are now currently on early diabetic, late diabetics patients are generally started on aspirin as a secondary prevention. So I just want to know whether the patient is on any other medications. On top of that, if the patient had MI, then it will be a high risk patient.
Okay. So it becomes a high risk for you require true early intervention.
Yes,
okay. Sir. Okay. So
Madam, one in chat box somebody asked about sudden cardiac death. I think it will be more important for some form of cardiomyopathies will be there, or HOCM patients. For that, that history is also important.
Yeah, rather than So history of what is the importance of asking history of having undergone a PTCA or undergone bypass?
To keep in mind about the restenosis also.
Okay. So already known case of coronary artery disease, undergone an intervention. So how do you classify MI?
It is classified into 5 types, ma'am. Type 1 is basically because of the plaque, ma'am. Type 2 is because of oxygen demand supply mismatch, ma'am.
Like example, like what conditions predisposed to demand supply mismatch?
Sepsis, shock, any hypovolemic shock or any other cases. There may be
more common things than sepsis. Sepsis, the patient has come to you. Somebody is already predisposed to develop an MI at home.
High exercise.
Perioperative MI, most common again.
They're all in the hospital. I'm talking about at home.
Exercise, ma'am. Exertion, exercise, post-exercise.
So if the patient had an underlying heart failure, patient had any sort of exertion over the heart failure, maybe like a fever, tachycardia.
Anemia is a very important condition. Okay, anemia, valvular heart disease, like we have aortic stenosis, where again there's no problem in the coronaries, but because of the low output state, you can have a mismatch between the so you can have a presentation like that. So type 2 is mainly in the hospital. Okay, you can think of sepsis and shock and hypoperfusion conditions, but outside of ICU or hospital, you should think of anemia. These are the more common things. Aortic stenosis, where the demand is much more than the supply or the bodies they provide. Okay, type 3 is, what is type 3?
Death due to high probability due to MI, ma'am. Type 3. Type 4 is post PCI patient and type 5 is post CABG patient.
Okay, they
Type
develop
4A, 4B is there in that. What is type 4A and 4B?
4A is post PDCA and 4B is post 10 thrombosis.
10 thrombosis. And type 5?
Type 2 post CABG.
Okay. Before coming to this one, what is the diagnostic test for the diagnosing patient having an acute coronary syndrome?
First is to take proper history, followed by ECG and high sensitive troponin I, sir.
In how much time you should take ECG?
Within 10 minutes.
Hospital?
Within 10 minutes.
Interpreted within 10 minutes.
ECG not only to taken, but interpretation has to be done within 10 minutes. That is the criteria.
Yes.
Okay. What are the other specific tests we sent for the patient having an acute coronary syndrome? Thinking of cardiac origin?
Yes, sir. Troponin I, sir. Or
Troponin I.
Yes.
Okay. Because you are giving the patient having history of diabetes for more than 10 years, sir. What are the non-cardiac causes which increases in the troponin?
The patient has background diabetic nephropathy or something causing that can again cause an increase in troponin.
Okay.
What are the types of troponin you have available? What are all the types of biomarker troponins we have available now?
INTs.
Troponin T and high sensitive
troponins also.
So what are the disadvantages or the false positives, false negatives with the troponins, both with related to the conventional troponins and with related to the high sensitivity troponins? Is there an advantage of one or the other? And what are the drawbacks of each of these tests?
Problem with the troponin is, yes, we can diagnose an MI, but if at all the patient had an post-PTCA or post-stenting, the re-MI cannot be diagnosed with the troponin because of the long half-life of the troponin to 7 days. Problem with high sensitivity troponin.
When does troponin normally become positive? After an MI or after a coronary event, when does troponin become positive?
4 hours is the start of the troponin to become positive, and it peaks at 12 to 24 hours.
10 to 24 hours too? It peaks at 12. And then how long does it last in the blood?
Nearly 14 days, ma'am. High sensitive is
10 to 14 days. Okay.
10 to 14 days.
Okay. What about high sensitive troponin? What is the advantage of that?
Advantage is even at very small levels of this thing, it is nothing much different, ma'am. Only based on the decimals, it is different, ma'am. High sensitive is taken in nanograms, whereas troponin is taken in micrograms, ma'am.
When is the duration of onset of rise?
Even
it also becomes positive with 1 hour period.
1 hour, within 1 hour also.
That is the advantage. That's the advantage. So early you can pick up the coronary event in a HS stroke. So what have you heard of any rule or something to rule out non-STMI in a patient? Have you heard of rule 1 R, rule in or rule out?
Rule in, rule out, ma'am. First, we have to take histories and all those things. 0, 1, and 3 hours of troponin, high sensitive troponin will take, ma'am. If all 3 are negative and no other changes also, then we can rule out non-STMI, ma'am.
Okay, so a negative HS trop I, usually can rule out aorta, acute myocardial infarction. Okay, yes. So no changes in the. So what is the advantage? How should you perform the single test is sufficient, or 2 or 3 or test need to be done troponin?
Ideally, up to 12 hours we have to repeat it, ma'am, because even there can be a late troponin release as well in a small MI. So ideally, we have to repeat up to 12 hours, and then we can safely rule out there is.
Yeah, so you need to follow them serially rather than seeing absolute concentration, single value, and then you have to fit it with the associated with the clinical syndrome. Then you can probably rule out or rule in an acute coronary syndrome. So, what are the other causes of, like sir asked, what are the causes of increased non-cardiac causes of increased troponins?
You told Vignesh told about some form renal of diabetic nephropathy.
Renal failure. Okay, renal failure is one important condition. What are other conditions?
Even pulmonary embolism can cause increase in troponin.
Troponin levels. Okay.
Yes. Even sepsis, burns, and trauma. All this can cause an increase in myocarditis. Also can cause increase in the troponin levels.
Yeah. So apart from coronary ischemia, myocarditis, even Takotsubo cardiomyopathy, important what we see in this thing. And then post-CPR, post-cardioversion, also you can see a lot of patients with increased troponin levels. So you can divide them again, classify them probably into myocardial injury associated without ischemia or with ischemia. all of them will have some amount of myocardial injury, but some will have with the ischemia, some will have without ischemia. So you need to classify it, then you'll remember the various causes of this thing. So in all these conditions, again, the serial values will be important rather than absolute value. Okay. In a post, like you said, in type 3 and type 4 and type 5 MI, so how do troponins help you in identifying whether there's a type 4 or type 5 MI?
So we look at the value, ma'am, actually, because if the value is more than 10 times more than the 99th percentile in a CABG, and post PCA it's 5 times more than the 99th percentile, then we call it as a significant level and we can diagnose as an MI.
Yeah, or a more than 20% increase from the baseline. Okay, if you have a PS value, then more than 20% increase. And along with that, you have new changes in the ECG or in the imaging, an echo or whatever. That's how you diagnosed. Okay. So now going on to the.
Madam, just
now
one minute.
Okay, yeah.
Because of this fallacies of the troponin, what are the other biomarkers we are utilizing for the acute coronary syndrome or cardiac things? Because we see a lot of fallacies are there with troponin, with all things are there, starting from the non-specific cardiac causes to the PT, the trauma, post-operative. What are the other biomarkers are there for diagnosing the acute coronary syndrome?
CKMB is there, sir.
CKMB we are using now?
No, sir.
Other newer novel biomarkers or newer biomarkers?
Copeptin is there, sir. Or one more is there, sir. Copeptin is there, sir, and FAB, sir. HFAB, heart-related binding protein is there, sir.
That is an ischemia-induced protein,
Yes,
fatty acid proteins, others.
And copeptin is there, sir.
Okay. What is their value when it is starting?
Sir, it starts as early as 1 hour, sir, and it peaks before 36 hours and slowly, gradually tapers off, sir.
That is the advantage of this newer biomarkers than the troponin, because troponin stays almost for 14 days. The reason even the post-operative troponin elevation is quite difficult for interpretation. Okay. Before coming that, patient comes to the for emergency room came, how you will manage the patient?
Now, first, let us go to the ECG diagnosis, no? Before Madhusudan. Yeah.
Okay,
so when you're first go to the clinical examination followed by ECG, both you will do. Okay. So first, how do you classify the acute coronary syndrome based on the ECG? Like how do you divide the ACS? What are the 3 types of ACS you are aware of? It is a cardiac ischemic pain, but you don't know whether it is what are the 3 types of acute coronary syndrome?
ST elevated MI, non-ST elevated MI, and unstable angina. Unstable
angina. Okay. So how do you differentiate between the 3? What are the criteria? How do you diagnose each of these?
So for STEMI, it is more than 1 millimeter elevation and all in the concurrent leads, except in V2 and V3, wherein for females we take a cutoff of 1.5, and in males more than 40 years it's 2.5, and more than 40 years it's 2, and less than 40 years it's 2. And for non-STEMI, ST segment.
No, ST, that's all in STMI. Anything else in STMI? 3 things
New
come under STMI.
New onset
LVBB.
What else? What's the third thing which comes under ST elevation MI? One is a contiguous ST elevation in 2 contiguous leads. Okay, I agree with you. That is 1. Second is new onset. What's the third criteria for labeling a person as ST MI?
Persistent ST elevations of more than 1 mm in 2 or more continuous limbs.
No, that is the one. That's the criteria you said. No, that's the first criteria. Second is a new onset LVB. What is the third criteria? Third condition which can also be labeled as STMI.
Angiographic evidence of complete occlusion of.
No. That's not ST elevation.
Ongoing chest pain, ma'am.
No.
We are talking about ECG diagnosis.
ECG, sir.
Another condition also you label as ST elevation MI. Which are the conditions you label as ST elevation MI? One is if you have 2 contiguous leads showing ST elevation according to the criteria you mentioned. Second is LVBB, new onset LVBB, which is not there previously. Third condition also which you label as ST elevation, equal importance as ST elevation MI. What is
pathological Q wave?
No. Posterior wall MI. How do you identify posterior wall MI? What are the ECG which are posterior wall MI?
ST segment depression and V2 and V1, V2 and V3, and we have to take a
posterior leads.
It's V7, 8, 9. Then we can again see that will be cutoff will be 0.5 millimeter.
No. What do you see in V7 to V9? ST depression or ST elevation?
Elevation of 0.5 millimeter is significant for the posterior leads.
In V7, V9,
And V2, V3, you see ST depression.
Depression will be there.
Okay. So, and a posterior wall MI also is also considered as ST elevation MI. It's also considered as MI. And maybe, and usually posterior wall MI is seen with which MI? Along with which MI?
RC.
No, which MI? Another associated MI is which is usually seen with posterior wall.
Inferior.
Another territory, inferior wall MI. Inferior wall. Okay. Okay. So that is for diagnosis for ST elevation MI. This is how you diagnose ST elevation MI. Okay. What about non-ST MI? How do you define non-ST MI?
Non-ST MI is again a new onset ST depression with a symmetrical T wave inversion. ST depression more than 5 mm. ST depression
More than 5. Okay.
0.5 mm and T wave inversion more than
0.5 mm. 0.5 mm, not 5.
T wave inversion more than 1 millimeter. Symmetrical T wave inversion can be called as an ST.
How do you differentiate between a ST depression of rate-related tachycardia, tachycardia-related ST depression versus a MI-related, non-ST MI-related ST depression? Both have ST depressions. Where you have fast heart rate, tachycardia
It will be either flat or downsloping, madam. If it is upsloping, then that won't come under ST.
Okay. So flat or horizontal or downsloping ST depression is more typical of a coronary syndrome rather than a upsloping ST depression. Okay. Okay. And these changes are usually dynamic. That's very important. So dynamic changes also can be seen. They may be seen transiently. They may not be seen again. So dynamic changes.
Hyperacute changes also can be seen.
That is more of STMI. Hyperacute changes is early part of a STMI, not a part of a non-STMI. Non-STMI is mainly ST depressions and T wave inversions. And sometimes they can have transient ST elevations also in a non-STMI. Yeah, but that's only transient. Most often they will have STT changes, ST depressions and T wave inversions. These are changes just seen in non-STMI. And unstable angina, how do you differentiate unstable angina from non-STMI?
Similar like non-STMI, but the cardiac biomarkers are not positive.
Yeah, they're not elevated. Okay. Okay. So in this, so once you get the ECG and you diagnose, sometimes the non-STMI, the ECG can be normal. So then what do you do? Say if you're having features of, typically the patient has features of coronary syndrome and pain is there, but you do an ECG and you don't find any of these ST depressions and all that, then what do you do?
On high observation, cardiac monitoring and repeat the ECG after 15 to 20 minutes.
But before doing that, you have to do a posterior leads. Again, I'm telling you to do the posterior leads. So you have to do the posterior because there may be only ST elevation or ST changes in the V7 to V9. So you have to do a posterior leads. So you may miss it on a simple, if you do a 12-lead ECG, routine 12-lead ECG, you may miss it. If the patient has typical symptoms, you observe, of course, you do a serial ECGs, you do serial TROP, you can do an echo, which will help you. And in addition, you have to do a posterior leads also to that you don't miss out a posterior wall ischemia, okay, which is not picked up on the routine 12-lead ECG. Okay. Okay. So, okay.
Madam, 1 minute. Actually, the patient having previous history of CAD, this patient, and previously already is having some conduction abnormalities are there. If the patient having a new onset of cardiac ischemia, how we are going to diagnose?
Conduction abnormality as in bundle branch blocks you are talking about.
Yes, bundle branch block is there for the patient previously. If you are seeing his old records of the patient, it is showing and bundle branch block is there for the patient. And patient came with typical symptoms of central chest pain, heaviness, radiating to the left side, thinking of the patient having an acute myocardial infarction. So that how we will diagnose that one?
We can
depending upon the areas of supply, we can have a new onset bundle branch block, sir.
Already patient having a bundle branch block.
We can apply Garbosa's criteria for that to diagnose.
What is the criteria?
So in concordant leads for elevation, it should be more than 1 millimeter elevation, and for depression again it should be 1 millimeter. And in a discordant waves, the wave should be negative with ST elevation more than 5 millimeter. So it will be given a scoring of 5, 3, and 2. If the score is more than 3, that gives a significance that the patient is having an MI.
So this can be used even for patients who are on a pacemaker. So somebody who already has a pacemaker also, somebody is on a RV pacing. Okay, they also have to follow the either Garbosa criteria or you can follow the modified Garbosa criteria. Do you know what is modified Garbosa criteria?
It's almost similar to this only, ma'am, actually.
Okay, you just go through it because that's more supposed to be more reliable in patients, especially whoever on a pacemaker. So a lot of patients can come on pacemakers and they can develop MI. So you should be able to identify such patients early. Okay.
Yes.
Yeah,
It
fine.
based on which trial they started Garbus criteria, modified Garbus criteria? Which was the trial?
Sorry, I'm not aware.
It's in Gusto trial. You have to read it because in the exams at your level, whenever some changes are there, what is the background is there, what are the trials are there, we should aware of that one. You should read about the Gusto trial also.
Yes, sir.
Okay.
What are the other investigations we sent for the patient? Have we done the ECG for the patient? We are done about the 2D echo. We done the tropi also.
Okay,
What are the
let
other
us go to
investigations?
this patient clinical examination. No, let us go to the clinical examination.
Okay.
Go on to the next slide. Go on.
So the patient is conscious, oriented, moderately built and afebrate. Pulse is 112 per minute, a BP of 100/60. Is saturating 95 minutes on room air with a normal respiratory rate. GBP is not able to visualize. On a cardiovascular examination, there is no parasternal heave or no tenderness has been felt. We are able to hear S1 and S2, and apex is felt at normal position. There's bilateral air entry is equal as well, and there are no added sounds. Abdomen also is soft and no ergonomically has been seen.
Okay. So in each of the examination findings, what are the things you look for specifically in a patient with acute coronary syndrome, and what is the importance of each of the examination findings?
So first,
Sensorium. First come to sensorium. You said sensorium of the patient. So what is the importance of sensorium when the patient has come to you with acute coronary syndrome?
the patient,
Cardiogenic shock is ruled out.
two things. One is cardiogenic shock. Other thing is if I want to thrombolyze the patient already, the patient old history of stroke, or again, that will be a factor actually when deciding thrombolysis.
Somebody's dementia also had their related contraindications, no, for thrombolysis.
Yes.
Yeah. Okay. Okay. Next is, of course, the vitals. So come tell me about the vitals, the pulse and everything, the vitals and the BP. What's the importance in a patient with acute coronary syndrome? So it says,
Bradycardia is commonly seen in inferior wall MIs, ma'am.
okay.
Tachycardia and all those things based on the pain and all those things we can correlate with that one. So that
Okay.
will be one.
In extremes of tachycardia will increase the demand as well. So that, that will,
Okay, that's important. What else about pulses? About the pulse, the
and
various pulses all over the body. Yeah.
all over the body. To rule out aortic dissection, again we have to measure our pulse all over the body.
So it's very important for us to rule out dissection in a patient with acute coronary why is it so important to rule out a dissection before we treat the patient for acute coronary syndrome?
Management is
We give
different.
no, ma'am. We have to give a loading dose. If we give a loading dose in these patients, that will be detrimental.
Yeah, it can be detrimental. So very, very important. Antiplatelets, even antiplatelets, simple antiplatelets, forget about thrombolysis. Even antiplatelets can be detrimental. If you give low dose in patients who already have a dissection, they can bleed. So this is very, very important. So we need to definitely rule out dissection very clearly before going on to treat the patient aggressively. Okay, that's about the pulses. And BP. What's the importance of BP in a acute coronary syndrome patient?
Cardiogenic to rule out any shock is there at present as well.
So how do you say cardiogenic shock? How do you define cardiogenic shock? When do you label a patient as having cardiogenic shock? Is there cutoff BP is there or anything cutoff is there? What is the BP? How do you say cardiogenic shock?
Less than 90 systolic actually with
Requiring vasopressor support.
or any will be requiring vasopressor support. We define it as a
How long for BP? For how long has to be more than 90?
20 minutes, ma'am.
Yeah, at least 20 minutes. So some people say 30 minutes, but okay, 20 minutes. Yeah, so less than BP, and they require after volume has been resuscitated, and then require vasopressor support. Then you take it as this thing. Along with that, what should be there? Not only the BP. BP is not the only thing which is
Cardiac
important.
symptoms.
Huh?
if there is or requiring vasopressor support.
Yeah, apart from that, very important. BP is not the only thing. What else?
Cardiac symptomatology of cardiac origin, ma'am.
Echographic evidence of low ejection fraction.
Okay, that is one. But what else? More important than that. How do you say cardiogenic shock?
Narrow pulse position.
When do you say cardiogenic shock? One is end-organ dysfunction, very, very important. End-organ dysfunction. You have to have signs of end-organ dysfunction in the form of what are the three main things you look for in end-organ dysfunction?
Sensory.
Tissue hyperperfusion. One you said no, altered sensorium. Altered mental status. What is
urine output?
Urine output. Next.
Warmth of the skin. If there is any.
Yeah. So skin cold can be peripheries or mottling of any skin changes, low perfusion, signs of low perfusion. And what about the testing wise?
Capillary filling time again actually.
No, I'm talking about labs or anything to help you in assessing the endogenous
Nitrates will tell us about
metabolic acidosis. And okay, so these are things. So, definition of endocardiac shock includes not only blood pressure, you have to also think of the endogenous dysfunction. Then only it's labeled as this thing. And now earlier criteria is also include cardiac index and pulmonary capillary registration, but now it's no longer done because we don't have you're not using a PA catheter or anything of the thing to calculate all those things now. So that may not be in the criteria, but at least signs of endogenous dysfunction and of course low blood pressure. These two are very, very important to label the person as having a cardiac shock. So sensorium, your skin changes, all these things are important in identifying a label patient. What about respiratory rate and saturation? What does it tell you?
Patient is in failure, then that will be getting patient requiring oxygen or increased respiratory, which tells us that again patient gone into failure. Pulmonary mass already been developed because of the failure, which can be.
So how do you assess the severity? Is there any classification or classing system which will tell you about patient is having a
Phillips classification is
Phillips
actually used to assess
so what is that? What is it based on? Phillips classification.
One, no evidence of pulmonary edema. Two, there are mild evidence of pulmonary edema in crackles and S3 calipers present. Three, again, definitely.
Crackles are present till what level?
Two, ma'am. Phillips
No.
class 2.
Yeah, up to half of the chest. So up to half of the chest posteriorly, you're able to hear the crackles.
Yes, ma'am.
Or you hear?
Three, ma'am. S3 gallop.
Okay.
S3
Okay.
Three, definitive evidence of pulmonary edema. Four, associated cardiogenic shock.
Cardiac shock. Okay. So this patient doesn't seem to have that because chest is clear, no?
Yes,
There's no
ma'am.
added sounds here. So this patient does not. So this patient come under what class of clip will he come under?
One.
Class
1. Okay. What is the importance of JVP in a patient with acute coronary syndrome?
Right heart failure.
Right heart, to rule out right heart failure.
Right heart failure. What do you mean right heart failure? Because of left heart failure, or what do you mean by right heart failure?
The patient having right-sided MI.
Right-sided MI.
So right ventricular MI. So right ventricular MI is associated with a raised JVP because of RV dysfunction. Because usually associated with RV dysfunction, they can have this thing. Or if the patient is in congestive heart failure, which is less likely, but somebody in cardiac shock, they also can have. So simple left, even without right ventricular failure, if somebody has a cardiac shock with the left heart failure leading to pulmonary hypertension, right heart failure also, that also can lead to raised JVP. Or what else can cause raised JVP in a patient with acute MI?
Any
In acute MI or in the post-MI situation, say patient has come to you after 3-4 days of an MI and patient has raised JVP. He does not have an RVMI, he does not have LV dysfunction. What were the possibilities? He's already come to you on 4th, 5th day of MI. A week after MI, he's come to you. Now he has raised JVP, his LV function is okay. And he has no RVMI and still has raised JVP. What were the possibilities?
Valvular.
valve rupture, anything?
No, there's no MR.
Fluid overload.
No. Why will he have fluid overload? He has no shock. He has no LV dysfunction. He has no MR. He has no RVMI.
No shock also, ma'am. No associated shock or chest pain or anything. Nothing is there.
Arrhythmia is
Not.
No. Which arrhythmia will cause raised JVP? What is Dressler syndrome?
fever.
Dressler syndrome.
In myocardial infarction patient having fever, ma'am, they'll.
More than fever, what is the feature of Dressler's?
Yes.
They'll have pericardial effusion. It's a post cardiac injury pericarditis. Pericardial effusion, that can lead to, they can even lead to tamponade also. Okay, so they can have a raised JVP. So these are things, so that's the importance of having a JVP, having the JVP in a patient with an MI, either maybe acute MI or in a old evolved MI also. They can have the first up to 6 weeks, they can have a Dressler syndrome. Okay. Okay, next go on. So what are other things you, so okay, next go on. This patient. So now how will you manage this patient? So you look for, what is the importance of saturation?
Target of saturation is above 90 to 93, ma'am. Don't give more oxygen is the major thing what we have to think about.
What is the problem with giving oxygen?
The infarct size increases, ma'am. And free radical injury also happens, and sometimes arrhythmias also can occur, ma'am.
So especially if you reperfuse and then also simultaneously increase oxygen levels, they can have a reperfusion injury and then oxygen toxicity. At the same time, hypoxia also can lead to what is the problem with giving not giving oxygen if the patient saturation is below 90.
The ischemia area can increase, ma'am.
So again, your type 2 MI kind of picture, where supply demand, the oxygen supply is less. So tissue again hypoxia are there. So that can lead to worsening of the coronary ischemia. You can worsen the coronary ischemia. What is the importance of murmurs? What are the murmurs you expect to see in a patient with acute coronary syndrome?
MR.
MR is one. Okay. What else? Due to MR. What else? What is the other murmur you can see?
VSD again
A transition murmur. Okay. What if you see an early diastole murmur in a patient who comes to you with chest pain? Okay, severe chest pain, very severe retrosternal pain, going to the back, and then you have an early diastole murmur. What do you do? What is the possibility?
No idea.
Severe pain ready to the back, and then you have on auscultation you have a diastole murmur, not a distal murmur.
Dissection.
Dissection. No, so how will dissection cause? So they have an aortic regurgitation. So the proximal type A dissection can have an aortic regurgitation, which will lead to a diastole murmur. So very, very important. You can pick it up there right itself that the patient is having a aortic dissection. Even if you don't have imaging till that point of time, you can you have a valve leak is going on. Okay. Yeah. Okay. So with all the examination and ECG and troponin, they probably have diagnosed patient to have a. So go on to the ECG. Next, these patients go on to the next slide. Okay. So what are you seeing in the ECG?
So we have ST segment depression with T wave inversion in leads V3 to V6 and V1 and ABL as well. That is
okay. So complete ECG diagnosis. What is the ECG? How do you tell me the diagnosis? ECG diagnosis of this with the history that she came to you with diagnosis.
No, this is end-stem
lateral wall, non-ST elevated.
Lateral wall. Area is the lateral wall. Okay.
How we can say about on the basis of ECG about which vessels are involved? Maybe the RCA, LCA, LED or LCX?
Generally based on the areas of supply, sir. Lateral wall is supplied by the LED, sir.
No. You tell me about the ECG diagnosis.
ECG. So
you
like
think about the
2-3 AVF will be inferior wall MI, sir, which is most commonly given by the RCA.
So can you tell even in more deeper in that, say inferior wall MI patient has ST elevation in the lead 2, 3 and AVF.
Yes.
So you're thinking of an inferior wall MI. So in inferior wall MI, can you tell me whether it's going to be predominantly RCA, likely to be RCA or likely to be L6? Because both can cause supply the inferior wall.
Yes.
Can you differentiate between the two?
patient has associated bradycardia along with it. And the patient also has patient also has some posterior MI along with 2-3 AVF. Then we can think it as an right circulation predominant in infarction.
No, it is based on the amount of elevation you see in lead 3 versus lead 2. Okay. So are you aware of that? If you see the amount of ST elevation, which is more in lead 3 compared to lead 2. Okay. And along with, what are the reciprocal changes? Where do you see reciprocal changes in inferior wall MI?
Lead
1 and AVL.
1 and AVL. So if you see reciprocal changes in 1 and AVL and you see lead 3 ST elevation more than lead 2, then it's more suggestive of a RCA, proximal RCA lesion. Okay. In contrast, if you see that ST elevation is same in both lead 2 and lead 3, equal amount of ST elevation, and you see the reciprocal changes in V1 to V3, then it is more likely to be LCX. And they may be associated posterior wall MI also in that. Okay. If you see ST depression in lead V1 to V3, along with ST elevation, which is nearly equal in lead 2 and lead 3, is more suggestive of a LCX or a distal RCA. More likely to be LCX or a distal RCA can be a possibility. Okay. Okay. Similarly, then what about anti-wall MI? Can you tell which vessel it is there in anti-wall MI? Whether how?
LED.
Yeah. So in anti-wall MI, how can you tell? And
predominantly LED, madam. And if septal also is involved, then we can think of main.
No, how would you tell whether it's the LAD is proximal part of LAD or the LMCA? Because they are more dangerous types. If the patient has some distal LAD, it's okay. You can still wait and the patient will not have a problem. But if you have a proximal LAD, how do you identify it? And if you have LMCA, how do you identify? Can you identify LMCA and
LMCA generally shows diffuse changes in V1 to V6, ma'am. And in lead 1, 2 and AVR also, ma'am, it can show changes.
No, so you'll have ST elevation in AVR and V1.
Yes.
Okay, but the ST elevation will be much more in AVR. Okay, compared to V1.
Yes.
That's one important sign of LMCA disease.
LMC.
And second thing, if you have something called QRBB, have you heard of what is called QRBB? What is QRBB? So an RBB pattern with in the V1, V2, if you see a small Q followed by an RBB, RSR pattern in V1. Okay, and ST elevation AVR. Okay, and ST elevation V1. If you sometimes see ST elevation V1 also, all these things are suggestive of a proximal LAD or a LMCA disease. It's more sinister. If you see an RBB pattern in a QRBB pattern in a V1 lead, RBB pattern in V1, V2, that is more suggestive of a more proximal LAD or an LMCA disease. Okay, it indicates an extensive antivolume. Okay. That's about the territory. Okay.
No other changes in the lead also. Then think about the left main disease is there. Okay, that is called as Widow's artery. That's very important. Most of the times we see the limb leads and the chest leads only. We don't bother about seeing about the other leads. That is the problem is there. So that AVR is very specific
AVR,
in that
very important, yeah.
is the most commonly missed, and we see the fatal events and complications happening for the patient.
So anybody who has ST elevation AVR indicates a proximal LAD or a LMCA disease. So very important note is the AVR in a ST elevation in AVR. We always see about the 1 AVL, V1 to V6, VC2, 3. We figured to see the AVR like what Madhusudan said. So very important to see the AVR in V1. These two will tell us about the more sinister complications of proximal left main or left main or proximal LAD disease. Okay. Okay. So in this patient, you think it's a non-STMI?
Yes.
Okay. So now what investigations you want to do? Other investigations apart from troponin? You've done the troponin in this patient. And what is the importance of GRBS in a patient with the acute coronary syndrome?
First thing is hypoglycemia may cause detrimental effects, ma'am, and we have to maintain sugars below 180, ma'am, for these patients.
So both hyper and hypoglycemia are not good for the post-MI patients. Okay, they can present with DKA. A lot of patients we see come presenting with DKA post-MI.
Yes.
Okay, so you should be very careful about good sugar control in patients with post-MI. Okay, it affects the mortality and morbidity post-MI. Okay, next slide. So now how will you move? Okay, what are the investigations, other investigations you will do in this patient apart from troponin?
First, basic CBP, serum electrolytes we'll send, ma'am. We'll send for an arterial blood gas to see lactate levels, ma'am. We'll do a
What
2
is the implication of Karthik? What is the why you want to take CBP? Because this is cardiac case.
Yes.
Only ECG and 2D echo is sufficient. Why you want to do CBP?
I want to maintain a target hemoglobin of 9 for these patients, sir, for adequate perfusions.
Okay, next.
And anemia also may be detrimental for these patients. Sir.
Yes, that is important thing. What else? Other investigations you sent?
Electrolytes, sir.
No, in CBP, what else is there? Hemoglobin, next.
WBC, sir. Hematocrit also, sir.
Okay.
What is the importance of WBC count in an MI patient?
If
Can I tell you anything?
If there is any increase again that can suggest infection which can cause tachycardia, again that can increase the demand of the.
No. Apart from sepsis, sepsis is one thing. Okay, there may be coincidence sepsis, but anything else with TLC will tell you?
Neutrophilic predominance is seen in MI patients, ma'am.
The non-infectious causes of the increase in TLC is because of the MI. Okay, so that it is not important every time increase in TLC count or the patient having temperature is not always sepsis. Patients of MI, patients of CBA, trauma, post-operative, all the patients have rise in TLC and temperature. Should not think it is an infection for the patient. What else will say other than that CBP?
And in fact, high TLC is found to be an independent predictor of a worse outcome after STEMI. So that is very important. So patients who come with very high TLC without sepsis in a patient's MI, they're found to have a worse outcome compared to those patients who come with the normal TLC. These are all a lot of other factors also which tell me other factors which predict the bad outcome after STMI. In a patient who has STMI, What are the factors which tell you that okay, this patient likely to have a worse prognosis? Okay, we'll come to it later.
Yep.
Okay, first I'll ask you what is it see in the CVP apart from TLC, hemoglobin?
Platelets also, ma'am. Target should be above 1 lakh, ma'am,
For what?
for the intervention, ma'am. If at all we are going for the intervention.
Why? Vascular intervention, you need 1 lakh. You don't need 1 lakh. We do vascular punctures, no, for above 50, no? You don't need 1 lakh for vascular. This thing, okay.
One of the indications are related to contraindications for thrombolysis or thrombocytopenia. And when you are using heparin, always you have to keep in the mind about heparin-induced thrombocytopenia. So that baseline platelet count is very important. So that in CBP, all these things are important. Other than that, CBP, what we send else?
Electrolytes.
Okay, why you want to send electrolytes?
Hyperkalemia, both will cause arrhythmia, sir, which may be again problematic for my MI patients.
How much should you maintain the potassium in post-MI patients? Ideally.
4.4.
More than 4.
So around 3.5 to 4, between 3.5 and 4.5. Not very high also. Again, both can cause problems. So again, it's recommended between 3.5 to 4.5. Because both increase the risk of arrhythmias. Okay, what about any other electrolyte? Is important?
Other than the potassium, what else we use? We do sodium, potassium, and else. What else we'll use?
Chloride and
Other
calcium.
than the chloride,
Calcium.
What? No.
magnesium is
Magnesium. Magnesium is important. Yeah. So in fact, post-MI hypoglycemia also is found to be associated with the poor outcomes and increased risk of arrhythmias and mortality. Okay. 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 Next.
Always keep in the mind electrolytes. Always ask for the magnesium also, because routinely we are not asking, and neither in ABG also available. That is the common mistakes are we forget to send magnesium, and then we have a lot of issues and problems.
Okay.
Other investigations, what we'll send for the patient other than the electrolytes? Other investigations?
Serum creatinine, sir.
Okay. Why important for the creatinine?
So because we use contrast for this primary and all those things, sir, it may cause contrast-induced nephropathy. So we have to have a baseline, sir. And it may, and patients in cardiorenal, patients in cardiogenic shock may have cardiorenal syndrome and all those things. And in old CKD patients and all those patients, we have to be careful about false raise in troponinize and all those.
And whatever the modification, any drugs need to be modified in patients with renal failure. The drugs they are going to use in acute coronary syndrome. Are any of the drugs require modification, dose modification in patients with CKD?
Enoxaparin, we have to dose modify if the patient is having increased creatinine.
What else? What are the other drugs which need to be modified in CKD patients?
Fondaparinux, again, if you are using, then again we have to modify it.
Do we modify it, or you should not give it if it's severe CKD?
Ideally, we shouldn't give it more than less than 30. It's
Yeah, less than 30 should not give fondaparinux. What else? What are other drugs which are used in the post-MI situation which are gone have a problem in CKD patients?
Ticagrelol.
Reciprocal actually has been reported to be.
And
NOACs are important. So they not of them need to be modified in some are not recommended in patients with
NOACs.
Oh yeah, NOACs are important. Okay. So this patient has undergone echo and troponin. So what is it? How do you interpret this?
Troponin is high, ma'am. Echo is also showing hypokinesia, ma'am. So
you need to mention what is the area, which is the area of hypokinesia. Okay. Territory, which territory is involved. So whether they're not mentioned here. Okay.
And already we reached to 8. Still we not came to the case.
It's okay. It's okay. It's okay. They say it's okay. So 8:30 also we can go on. Yeah, it's okay. Okay. Next, how do you manage this patient now? So now what is the final diagnosis now? And then how will you manage the patient based on the echo report, troponin report, and then you have other CBP reports available. Now, what is the immediate treatment of what is the immediate treatment plan for your patient? What is the diagnosis and immediate treatment? What you want to give?
So this patient actually had a lateral wall MI, and the patient also had actually starting to develop hypertension, maybe in a cardiogenic shock as well, madam. So this patient, apart from starting our routine.
No, diagnosis. For first diagnosis, non-STMI.
Non-STMI.
With cardiogenic shock, you're saying.
Cardiogenic shock.
Okay. Where the okay, where the definition of cardiac is not fitting. Creatinine is 0.8. Okay.
Patient is started on noradrenaline. So
How do you advise? So what do you think is the cause for a patient developing hypotension? You think it's could be cardiac shock or it could be something else?
predominantly cardiogenic, ma'am, but sometimes vasodilation also can take in these patients with MI because of the inflammatory response which happen post MI. So,
Patient was given nitrates, no?
yes, ma'am.
Yes.
So do you give nitrates? What are the indications for giving nitrates in this patient? When do you give nitrates in a patient who comes with non-STMI or STMI?
Ongoing chest pain.
Ongoing chest pain, we give
Ongoing
nitrates.
chest pain with hemodynamic stability only, we give nitrates, ma'am, or else we don't give nitrates in a hemodynamically unstable patient.
Okay, what are other contraindications of nitrates?
Patient already taking any phosphodiesterase inhibitor within the past 1 day. Patient is, again, we won't give nitrates.
Okay, what else?
Right wall MI, RDMI, again, we won't give nitrates.
Okay, in favor, right ventricular MI, be careful because they all can have hypotension. Okay.
Hypotension.
Hypotension. Okay. So now how will you manage this patient?
So this patient, since though NSTEM patient having an ongoing shock, the patient was taken up for CAG to look.
No, forget about CAG. Management, what will give immediate management? What is the immediate management you give for the patient? A patient comes to you with, now you said non-STMI,
Yes.
most likely lateral MI.
First, we will take
Loading with the aspirin 300 milligram, madam. And
What aspirin? What aspirin? How will you give it?
Sir, we will ask them to chew it.
non-entry coated aspirin we have.
Okay. Okay.
And we'll ask him to chew it, ma'am.
Okay.
And 300 milligrams of aspirin, and we'll give. We have already given nitrate to this patient, ma'am, and morphine also we have given to this patient, ma'am. We can start him on before this patient started developing hypotension later, ma'am. In the starting, because of the heart rate, we have given a beta blocker also for him, ma'am.
Okay. And what else can you give? What is I supposed to give?
Clopidogrel also we have.
And statin, ma'am. Loading dose of dual antiplatelets and a statin we have given.
Now which dual antiplatelet are you going to give? Which is the second antiplatelet you want to give?
Aspirin and clopidogrel we have given them to this patient.
We are saying that patient is going for CAG. What is the recommendation at present if patient going for CAG?
Ticagrelol of 180 milligrams, sir.
Loading should be given.
Loading should be given.
Nowadays, if interventions are planning for the people, they are giving and dual antiplatelets, including ticagrelol. Okay, how much the dose?
180
milligrams.
What are the contraindications for? When do you not give? When do you go for clopidogrel instead of these newer antiplatelet drugs? In both STMI and non-STMI, when do you go for the older clopidogrel rather than going for new ones? In which conditions?
Patients in failure and in atrial fibrillation.
No. Instead of ticagrelol and prasugrel, when do you go for clopidogrel? Now, recommendation, like you said, when you're going for PCI or you're going for intervention, it's always better to give a ticagrelol or a prasugrel. When do you give clopidogrel? And is there advantage of one over the other? Prasugrel and ticagrelol, is there any difference between the two? Is one preferred over the other?
In normal patients,
how do you choose which antiplatelet to give? Second antiplatelet, how do you choose?
In normal patients and non-STMI with no this thing, prasugrel is recommended, ma'am, in recent guidelines. But previously, in patients with already on antiplatelets, ma'am, already they will be given clopidogrel.
And already on aspirin or already on antiplatelets?
Patients who are already on antiplatelets, they will be given
antiplatelet on aspirin. Patients already on aspirin or patients already on clopidogrel?
Already on clopidogrel, ma'am.
What are the contraindications of prasugrel? You should not give prasugrel in which group of patients?
More than 75 years, we don't give prasugrel.
And
recently,
contraindication?
ischemic stroke patients we don't give, ma'am.
Patients have a history of ischemic stroke. A TIA or ischemic stroke patients also, they are better not to give prasugrel. They are better to go for ticagrelol can be given in that situation. It can be given.
Yes, ma'am.
Can be given in some situation. And elderly patients, better. What's the dose of clopidogrel you give in elderly patients?
Half the dose.
No loading dose.
No loading. There is no change, ma'am.
We won't.
Yeah, this you have to be very clear. Okay, when you give what dose of which medication. Okay, you need to go read this.
Yes.
There's a lot of confusion. So you have to see whether when the patient is going for PCI, when the patient has contraindications, and then when the patient is elderly, or how do you assess the bleeding risk in any patient? There are certain scores which will tell you whether the patient has a higher bleeding risk. Okay. So based on all those factors, you have to decide whether you want to go for the newer antiplatelets or stick to clopidogrel, and even clopidogrel, you have to decide what dose you want to give. So all this will be decided upon based upon the risk factors for bleeding and risk factors for ischemia. Okay. So the risk factors for ischemia are more or risk factors for bleeding are more. Based on that, you can decide about the risk. Okay. So what else you do in this patient apart from antiplatelets, and how do you decide whether to take for patient for early PCA or you just want to wait for medical management?
Ma'am, this patient is having ongoing chest pain, ma'am. It is one indication for directly taking up for a PCA, ma'am.
Okay. One is that. Second?
Yes, ma'am. And ECG changes suggestive of ischemia and troponin positive. These three are indications.
No, they already patient already has troponin positive,
Yes,
already has
yes,
ECG changes. So what are the things in a patient already known case of your diagnosis as non-STMI?
Yes, ma'am.
How do you go for when do you decide to continue the patient medical management and wait and watch and then do a regular coronary angio later on, or when do you take them for early invasive strategy?
Hemodynamic
Hemodynamic
instability.
instability.
Patient having any VT or life-threatening arrhythmias is happening, then again we take them to the patient for.
What are the scores which are available which will help you in determining the risk of worsening? Based on the scores, you will take the patient for early invasive, or you'll just take them for very early invasive.
TIMI score is there, ma'am. TIMI score is there, ma'am.
More important than TIMI score?
Grace score we actually use to decide whether.
So Grace score is much more validated. So Grace risk score is much more validated than TIMI score. Okay.
We get the points more than 140, then the patient has to be taken up for CUD.
Yeah, so any patient who has a high risk Grace risk score or who has hemodynamic instability, ongoing chest pain, ongoing ECG changes, dynamic ECG changes. Okay, so all these situations you have to think of take the patient. Our patient has been already on aspirin, so all this come under the Grace risk score. They'll tell you so you need to know what are the factors which are a part of the Grace score. So you calculate the Grace score, then you see whether the patient is high risk or a low risk for a worsening. Then you decide about taking for PCI. Okay. So,
what are the indications for thrombolysis? If two things are there, if your center is capable of doing PCI, we go ahead for the PCI. If not, then you go to thrombolysis. What are the guidelines says?
Say the patient had STMI rather than non-STMI. Same thing, patient had a say posterior wall, posterolateral and inferior and posterolateral MI. Say patient came to you with the because subsequent ECG, if you see some ST elevation in the inferior leads also, in posterior leads also, patient had ST elevation, say, and patient went into an ST elevation MI. Now, what do you do? What's the next treatment?
PCI center, if center is PCI capable, directly go ahead with PCI. Okay. Center is not PCI capable and the patient can reach a PCI capable center in the next 120 minutes, we can transfer the patient. If not, then the patient has to be thrombolyzed within 30 minutes of reaching the hospital.
What are the medications we use for thrombolysis?
Fibrin specific and non-fibrin specific medications are there, sir. We use fibrin specific like altiplase, retiplase, or tanactiplase.
Okay. So, what if say if your center is primary, can do a PCI immediately? What is the ideal recommended door to balloon time?
Less than 120 minutes.
If the center is primary, your center is capable of doing a PCI. If a patient comes to you, reaches the thing, and your center has the capacity to do a PCI. Okay. What is the ideal time recommended by which you should finish off your balloon dilatation?
Less than 90.
90 minutes. Ballooning is 90.
60 to 90 minutes. So between 60 to 90 minutes, you finish off the PCI. If your center is capable of finishing. PCI. Yeah. And by thrombolysis, it should be done within
30 minutes.
What is door natal time? It should be in 30 minutes.
30 minutes.
That is 30 minutes, and PCI should be within 60 to 90 minutes. If you are sent to another center for PCI, that they should reach there by within
120 minutes.
120 minutes. Okay. So when is the best time for thrombolysis? After an MI, patient comes to you symptom onset, after symptom onset, what's the best time? The maximum benefit of thrombolysis is seen in the which time? Up to what time?
Up to 12 hours.
12 hours.
No, the maximum benefit is
12
seen up
hours?
to what time?
4 hours, ma'am.
3 to 4 hours. Yeah. So before 4 hours, the maximum benefit of thrombolysis.
Yes.
So that's the reason if the patient comes to you within 4 hours, and if you're not able to send to a PCI center, there the thrombolysis will have much more advantage over sending the patient for a PCI and delaying the PCI revascularization. But the patient comes to you between 4 and 12 hours, then is there advantage of thrombolysis or is there advantage of PCI? Between 4 to 12 hours.
4 to 12 hours also we should thrombolyze, ma'am. But as early as possible, we can go ahead for PCI.
Yeah, but even there, even slight delay in the PCI may not really harm the patient much, and it won't help also much. So there's equal benefit in, if you say PCI, there's no advantage of PCI if you do it between 4 to 12 hours. Beyond 12 hours,
No role of thrombolysis.
so there's no role of thrombolysis. So definitely you have to go for a
PCI.
PCI. Okay. So what do you
What are
mean
the
by
drugs you're using for thrombolysis?
Tenecteplase, sir.
What are the doses?
Tenecteplase is weight-based dosage, sir.
Mhm.
Below 65 kgs, we give 30 milligrams, sir. Above 65 kgs and based on 70 to 80 kgs, we give 40 milligrams, sir. Above 80, we give 50 milligrams. Like that it is there, sir. Weight-based dosage is there for tenecteplase, sir. For retiplase, it is 10 international units as first bolus, followed by second after half an hour, sir. Whereas altiplase, it is 100 milligrams over 1.5 hour period, sir. First we give 0.15, later in 30 minutes and in 60 minutes we give 100 milligrams, sir.
Which is the most commonly used?
Tenecteplase, sir.
Why?
Sir, it is more fibrin specific, sir, and because of that fibrin specificity, we use tenecteplase more.
Two things. It causes us less hypotension also and less IC bleed as compared to the other drugs.
Yes.
Yeah, less hypotension is very important. It's a bolus dose, so less chance of hypotension. Very, very important. So the patient, even with the borderline pressures, will tolerate tenecteplase better compared to tolerating altiplase or other like STK and other drugs.
And
Okay,
single
so-
bolus dose we can.
Yeah, it's fast, much faster also.
What are
So
the contraindications for thrombolysis?
Sir, any patient having intracranial hemorrhage, sir, or acute ischemic stroke within 3 months, sir, and patient having active bleeding or aortic
No, no.
dissection.
The first indication which is there for the patient having an acute ischemic stroke, and if his thrombolysis is done within 3 hours, is not a contraindication.
Yes. Okay.
Okay.
That you have to keep in the mind. Most of the people think that acute ischemic stroke coming within the time 3 hours, done in thrombolysis is not a contraindication by doing thrombolysis.
Okay.
What are the other
So-
contraindications?
Any active bleeding, aortic dissection, then hypertension, sir. BP more than 180 by 110. We have to get it down and then we have to thrombolyze those patients, sir. Pregnancy is also a relative contraindication.
And post CPR, traumatic CPR,
CPR.
prolonged CPR. Okay.
What about the menstruation? Is
No
contraindication?
Not
contraindication.
contraindications.
How much the platelet count should be there for the thrombolysis?
1 lakh, sir.
More than or less than?
More than 1 lakh should be there, sir.
What
But
about the
to
other
the-
non-fibrin specific drugs we are using for thrombolysis?
Streptokinase, urokinase, sir.
Okay. What are the doses?
Sir, streptokinase 2.5 million units, sir. Urokinase
No,
is
2.5. No,
Right.
2.5. You're not.
Why?
Streptokinase. What's the
first
dose?
followed by infusion we'll keep. First
Streptokinase.
we-
No. You're talking about PT. You're talking about MI.
we
In
can
PT, that's what you're talking about. You're talking about 2.5 lakh units followed by 1 lakh
Followed
units
by
per
1
hour.
lakh.
In MI, what's the dose?
15 lakhs. I didn't use it, ma'am, but I just read about it.
Which hospital? Yashoda is give only altiplase, huh? All rich patients come there. Okay. Okay. So anyway, so what is the indication? What do you mean by primary PCI? What do you mean by rescue PCI? And what do you mean by ad hoc PCI?
Primary PCI is when the patient comes directly, we decide the patient has to be taken up for PCI. That is primary PCI. Rescue PCI is only after thrombolysis or fibrinolysis. Then we feel that the patient is not responded to the treatment in terms
How
of
do you decide? How do you come to conclusion patient is not it's not a successful thrombolysis or it's a failed thrombolysis? How do you decide?
Less than 50% decrease in the ST elevation.
STD changes or no improvement in cardiogenic shock or chest pain, again we term it as non-responsive to treatment, and then the patient will be taken up for PCA. So that we call it as a rescue PCA.
Okay. So in which conditions primary PCA? Say if the patient comes to you, especially within 4 to 5 hours, and then you have a PCI capacity. What is the advantage of, especially which conditions of acute MI you're supposed to do a PCI is much more advantageous than a thrombolysis? And which conditions thrombolysis is more useful than a PCI?
Not sure.
No, PCI, especially the patient has cardiogenic shock, patient is in heart failure, okay? Or of course, patient has a contraindications to fibrinogen therapy or out of window period like more than 12 hours. So in these kind of situations, definitely primary PCI has much more advantages compared to especially shock patient. If there's a delay by a few minutes or something beyond the 120 minutes also, you should still take the patient for a PCI center rather than do thrombolysis in a patient who is in cardiogenic shock, because the mortality is very high if you do only thrombolysis. So patient has cardiogenic shock and heart failure, is better to go for PCI even if it's a little delayed rather than going for thrombolysis, because outcomes are not very good with thrombolysis alone, okay, in those patients. What do you mean by pharmacoinvasive strategy? What do you mean by pharmacoinvasive strategy?
No idea.
This is what you said, no, just now, rescue PCI, where you
No,
rescue or otherwise, where you do a pharmacological therapy and may not be rescue, but after a pharmacological thrombolysis, in the first 24 hours, within 24 hours, you shift the patient to a center which has a PCI capability, and then you plan for a PCI. That is called a pharmacoinvasive. Initially, you do a pharmacological therapy because you don't have the facility for PCI. Then following that, within the first 24 hours, you shift him to a PCI center, and then you go ahead with the planned invasive PCI. Okay, you go for that. That is called a pharmacoinvasive strategy. But sometimes the patient has a failed thrombolysis, and you have to go ahead with the emergency PCI following a thrombolysis therapy. Otherwise, you can wait for up to 24 hours and then go ahead with the PCI. Okay.
Yes.
What about anticoagulation? And how about antiplatelets in a patient who undergoing post thrombolysis or post PCI? How long do you give? What antiplatelets do you start? And what anticoagulation will you start?
Aspirin is going to be lifelong, madam. And the second
lifelong.
12 months, ma'am.
Like the second antiplatelet, we are going to give until 12 months. Aspirin will be continued indefinitely.
Okay.
And
so it's second. And again, duration of second antiplatelet will depend. Duration of second antiplatelet will also depend upon the risk of bleeding for the patient. So always you have to, there's some scores which will tell you about the risk of bleed in any patient. So it's not for the ICU doctors, but for the cardiologist or later on for managing a patient. So the duration of antiplatelets for 6 months or 12 months, or you're going to continue beyond 12 months, will all depend upon the risk of bleeding that the patient has. Okay.
Yes.
So at least minimum 6 months is recommended for all patients, especially for bare metal stents for 6 months is okay. And for dilating at least for 1 year. But beyond to continue for beyond for 1 year or even to bring down to 6 months, there are a lot of factors, especially the risk factors for bleeding has to be taken into consideration before deciding for these things. Okay. What about anticoagulation?
Anticoagulation, before sending to a PCA, we have to start anticoagulation. After coming also, we have to start and then we can continue up to 8 days, madam.
No, before PCI or before thrombolysis, you start anticoagulation. Okay. What is the anticoagulation choice? What do you start with?
Heparin.
Taken up for PCA, then heparin will be the choice.
Ma'am. Or else low molecular weight heparin is
low molecular weight.
So, okay, the patient undergoes a PCI. How long will you give anticoagulation after the PCI?
Total of 8.
After PCI, if you do a PCI, how long will you give it? If you do thrombolysis, how long will you give it? Only thrombolysis, how long will you give heparin? If it's PCI and we said revascularization, how long will you give?
72 hours, ma'am.
A non-STMI, how long? If you don't do an invasive strategy, if you just don't go for an early invasive strategy, how long will you give it?
Not sure of the cutoff.
So please say, so if you do a PCI, you can stop the anticoagulation immediately after the PCI. Unless the patient has some other indication of anticoagulation like a AF rate fibrillation or something else, or he's on NOACs or something else, or he's on anticoagulation or something else, you can stop anticoagulation after a
PCI.
successful PCI and you have reassured the patient, you can stop the anticoagulation. If it's post-thrombolysis, you have to continue it at least for 7 days, 5 to 7 days if you don't do a PCI in between. If you do a PCI, again, you can stop it once you do a PCI. Same thing for non-STMI. Again, you continue anticoagulation for till you do the PCI. Okay, it may be at least for 5 to 7 days you have to give it. Okay?
Yes.
Fine. So if you do a PCI, you can stop the anticoagulation. Okay. So the
When you
patient
are
already
doing
on
in PCI, when you are doing in PCI, which vessels will open? We discussed about the territory of the arterial territory. If the lesions are there in the ECG, we seen the lesions are there in the LED, and we have some lesions in the RC also.
like for this patient has lesions in all three, no? See the angio report of this patient?
Yes.
Yeah, so it's showing a vessel, all three vessels are affected, no? 70%, 95%, 90%.
Yes.
So in this, say if this patient for a PCA now, he has you taken him because he's having ongoing cardiogenic shock. Patient has cardiogenic shock, non-STMI, but he's having cardiogenic shock. And you've taken him for a emergency PCI. You've done an angio, emergency angio, and you found three vessels are affected. He said multi-vessels are affected. So now do you go for a single vessel, only the vessel which is causing the posterior wall? You had lateral wall, no?
Yes.
Changes. So you only go for lateral wall, that culprit vessel, or you'll go for the all the three you'll revascularize?
Lateral wall will be going.
All these
Lateral wall will be going because that is a culprit which is causing the cardiogenic shock. No, so will be.
So what's the current recommendation? What's the current recommendation? Whether to do a culprit vessel PCI or should do a simultaneously multi-vessel PCI, or you do culprit vessel, then you do staged PCI later on for the other vessels? What's the recommendation?
culprit vessel will do. Culprit vessel will do first, ma'am. Later staged PCI to the other vessels.
Which study is telling you that?
Which trial is there?
Trial is there.
You have to know these important trials, okay? In patients with them, especially for revascularization. Though this is a controversial topic as of now, but there are at least whatever data is available, the recommendations, both the European and the American, they have recommended that you do a culprit vessel first, as of now. So they have to know about the study.
Culprit shock.
Culprit shock study, okay, trial, where they showed that risk of renal failure and death is much lesser if you do culprit vessel compared to if you do a multi-vessel PCI. And they've given several reasons for this result, probably because of the dye, amount of dye you use and all these things, and a lot of fallacies in the study also. But still, as of now, with the data available, it is still culprit vessel versus a multi-vessel PCI. Okay, but probably there are some new studies which are coming up which are giving data that probably multi-vessel also is safe, and the 1 year outcomes and 6 month outcomes much better if you do a multi-vessel PCI at the same time rather than doing a culprit vessel first followed by a multi-vessel PCI. So the data is still controversial, but as of now, the recommenders still recommend only culprit vessel. But you have to go through the latest study which have shown this data. Okay. So now this patient can be, okay, if the patient is suitable for PCI, you can go for a PCI. Otherwise, what do you do? Say this patient is not suitable, the vessels are not suitable for a PCI. The lesions are not suitable for PCI in this patient. He has TVD and it's not suitable for and the patient is in cardiogenic shock. What do you do now? He's not suitable, the vessels are not suitable for a PCI.
The role of IABP?
A lot of calcium or very long lesions or something.
No major role of IABP for this patient, sir. But we can, if there is severe shock, we can use, sir. Shock 2 trial has given no benefit of IABP, sir.
But as a bridge for doing the
As a bridge to bypass, we can use it.
Yes. Bridge to definitive therapy, yes, we can use IABP there. Yeah, in this case.
Okay.
Bridge to bypass or bridge to PCI. So what is the indication for IABP in cardiogenic shock? Secondary to MI. What are the indications for?
Ongoing chest pain.
Hypotension.
My cardiogenic shock. I already said cardiogenic shock. MI with cardiogenic shock. What are the indications or benefits of using an IABP?
Refractory to medical therapy, And again, if your center is not a PCA, you are going at for a thrombolysis with the cardiogenic shock. Again, AABP we insert, and then again they go for a thrombolysis simultaneously, because that has also been tried.
No, it's mainly as a bridge during
Mainly
PCI.
as a
When you're doing a PCI, during PCI, you can use it as a temporary measure till you do a PCI, or you can use it as a when you're taking a patient for patient has mechanical complications like DSD or MR or mechanical complication. You're taking the patient for a CABG. So till the patient starts, you start the CABG, you do the CABG. You can put an IABP as a bridge for before PCI or during a PCI or during a perioperative period for the CABG. Okay, but standalone IABP for cardiogenic shock, as of now, the data is not in favor of a IABP. It does not improve the outcomes in this thing. What are other complications of acute coronary syndrome, STMI or non-STMI? One is cardiogenic shock. We discussed that. Then, of course, cardiogenic shock. One is, of course, treating the revascularization is the most important treatment. What are other treatments for cardiogenic shock?
Vasopressor support.
Okay. What else?
Rhythm control, ma'am. Rate and rhythm control.
What else?
Then, if higher, then we can go for VA ECMO also, ma'am.
Okay. So after revascularization, the LV function is very bad in the patient in cardiogenic shock. Then, of course, ventricular assist devices can be.
Yeah, LVADs.
support.
Just name some of the device you know.
HeartMate is there, ma'am. Tandem heart is there, ma'am. And Impella. Yeah.
Impella. Okay. Okay, fine. What are other complications of acute coronary syndrome or STMI, ST elevation? They can be seen both in ST elevation and non-ST elevation, but more commonly, what are the complications?
Papillary muscle rupture, free wall rupture, arrhythmias, blocks, and VSDs. Cardiac tamponade.
More common, heart failure.
Heart.
LV dysfunction is heart failure. How do you manage heart failure patient? How do you manage a patient who has some MI, post-MI heart failure?
We initially start on suppressors.
Decrease the afterload and preload, ma'am, and afterload also. So we use nitroglycerin for these patients, ma'am. We use diuretics for these patients.
What else?
Inotropic supports, vasopressors can be given, ma'am. Cardiac glycoside. No.
Most important, you're not telling in heart failure. NIV you will not give?
NIV.
Yes, sir.
Important, no? Does it help? CPAP or BiPAP help in pulmonary edema?
Yes, ma'am.
Cardiac pulmonary edema. Is there a benefit? How does it help? How does it work?
It increases the for pulmonary edema. It actually increases the intrathoracic pressure. Actually, so it decreases the afterload for the LV and increases the preload. So thereby
decrease the preload and decrease the afterload.
Yes.
Both are decreased.
Yes, ma'am. Decreases the preload and decreases the afterload for the LV.
So which is better, CPAP or BiPAP? Is there an advantage one or the other, or there is
CPAP only. CPAP only, ma'am. Continuous.
So what are the bad arrhythmias you know? What are the bad arrhythmias which are seen in patients, and which MI is it more common? And can it be seen in okay, tell me what are the bad arrhythmias you know of?
Sinus bradycardia and heart blocks, ma'am. Class 1.
It's more common in which MI?
Inferior wall MM, right coronary artery involvement, if it is there, then we say bradycardia. Okay.
So sinus brady is more because of both the SA node and AV node supplied by which?
Right coronary artery.
Right coronary.
Both are right coronary.
SA node is by right coronary, ma'am. AV node is also supplied, but branches of the left anterior descending come to the.
No, LAD doesn't supply the SA node or AV node at all. It's LCX.
LCX.
It's a common LCX and RCA will supply the SA node and AV node. Okay. So SA node is 60% by RCA and 40% by LCX, but AV node predominantly supplied by the RCA. Okay. But can you see bradyarrhythmias even in anti-wall MI?
Left dominant hearts, yes, ma'am.
No, can you see bradyarrhythmia? If you see bradyarrhythmia in a patient with some AV block, you're seeing in a patient with the anti-wall MI versus seeing a AV block in a patient with the inferior MI. In which case you're more worried, and why?
LAD.
Say if you have a second degree AV block, if you have a Mobitz type 2 block, second degree Mobitz type 2 in a patient with inferior MI versus you have a Mobitz type 2 in a patient with anti-wall MI. So in which condition will you go for a pacemaker, temporary pacemaker? In which condition will you wait?
Ma'am, both will go for pacemakers, ma'am. But in LAD, we have to be, in anterior wall MIs with fascicular blocks and all those things, ma'am. Type 2 blocks, it is more of LMCA territory, ma'am. So we have to be more vigilant about this.
No, because it indicates whereas it's only a AV nodal or just a little below the AV node block in case of a inferior wall MI. Whereas if you're having a block in a case of LAD territory, that means extensive involvement, extensive necrosis of the myocardium is there. That's leading to the significant damage to the myocardium, which is causing the loss of bundle of his and below bundle of his. And the ventricular escape will usually be much lower. So ventricular escape will be much lower, will be less than 40 it will be. Okay. And they will require a permanent, most often they will require a permanent pacemaker because of extensive myocardial injury. Very unlikely that it will recover. Whereas if it's an inferior wall MI, if you have a AV block, it's usually because of the AV nodal or SA nodal or AV nodal blocks. Basically, AV nodal or just below the bundle of his. So there, the chance, the escape rhythm also is more than 40 to 60, and they usually recover over a period of 5 to 7 days. So even simple temporary pacemaker, you just keep and watch for the BP and other parameters. And then if the patient, mostly they will respond and they'll recover within 5 to 7 days without recovering permanent pacemaker. Whereas there's a very less chance and very absolutely no chance of recovery if a patient has a AV block, high degree AV block in a anterior wall MI. So definitely better to go for an early PPI in those patients rather than waiting for or trying to remove the TPI. Okay. So that's a very important. So it's much more significant in the anterior wall MI rather than a inferior wall MI. Okay. Anything else you want to ask, Dr. Madhusudan?
Which patients regarding this patient were having shock? Whether we can give the fluids for these patients?
The patient is having RV MI, yes, we can give fluid, but judiciously again can be given.
Okay. Okay, this patient already we kept on NIB, started on vasopressors. Now he requires an intubation, mechanical ventilation. I will proceed for intubation and mechanical ventilation.
I'll use ethambutate for this patient, sir.
Okay.
It's cardiostable, sir, and I would try to maintain. I try to prevent hypotension for these patients, sir. And low amount of PEEP I would use, sir.
Okay. What are the other drugs other than intermediate?
Fentanyl I will use, sir.
Can we use ketamine?
No, sir, it will increase the heart rate.
Demand will increase.
Okay. What are the monitoring devices we'll keep for this patient? Patients of cardiogenic shock. What are the monitoring devices we'll keep? We have an arterial line. Other than the arterial line, what are the monitoring we'll do for the patient?
Cardiac output monitoring will be keeping. So.
Okay.
The patient is having an RV failure as well and going up for surgery. Maybe intraoperatively they may take up PA catheter.
Okay.
Okay. What are the tracking?
If the patient having an VSD, what will changes we see in the PA catheter?
There will be a step up of saturation in the RVs actually. It will tell us that the patient is having a VSD.
Yes, that is the most common complication happens post-MI for the patient which going for the surgical intervention. The return for the patient which are having TBD, but the post-MI also patient having complications of MR, papillary muscle rupture, VSD, or the patient having a left ventricular aneurysm. They're all indications for going for CABG for the patient. Okay. Okay. Patient
Okay,
has
what
been
are the-
controlled. Yes, madam. Yes, please.
No, what are the tachyarrhythmias you are expecting a patient with any ST elevation? Am I admitted or any MI admitted in the ICU? And when do they usually occur? And how are there any measures for us to prevent them to a certain extent? Can we prevent the tachyarrhythmias from happening? What are the common tachyarrhythmias you identify?
Atrial fibrillation and ventricular tachycardia, VT.
And VTVF, okay. So supraventricular is AF, okay, and then VTVF. So what about how can you prevent the development of arrhythmias, tachyarrhythmias? Are there any drugs or anything which you can do to prevent or decrease the risk of tachyarrhythmias?
Magnesium we can give and we can maintain normal level. That will
Yeah, so you have to maintain magnesium above 2 and potassium, like we said, above 4, between 4 to 4.5. Okay, what else can decrease the risk of post MI arrhythmias?
Early.
pain.
Any drugs, which is very important drugs we give, no, post MI, all patients we give most, if
Beta
there's no
blocker.
contraindication. Beta blockers. So beta blockers decrease risk of tachyarrhythmias. Okay. And also we are, of course, revascularization is the most important thing to prevent tachyarrhythmias. Okay. So and then you have to, what is any role of what is non-STMI? What is a NSVT and what is this sustained VT? How do you define NSVT and sustained VT? When do you say non-sustained VT? And when do you say sustained VT?
Irregular rhythm, non-sustained.
No, VT. VT is regular or irregular?
After shock,
It is regular.
after
No,
giving,
what is non-sustained VT? What is sustained VT?
even after a synchronized cardioversion, if the VT is
No.
Polymorphic, monomorphic.
There is monomorphic and polymorphic, that's different. In monomorphic or polymorphic, when do you say monomorphic, especially when you say sustained VT and non-sustained VT? When do you say VT in the first place? Or what would you say VPCs versus VT? How do you say VPCs or VT?
regular broad complex tachycardia.
Yeah, VPC also we have broad QRS, no? VPC also we have broad QRS.
Rate
So VPCs versus VT, again VT, NSVT, non-sustained VT versus sustained VT. How do you say it on ECG monitor? If you have more than 3 consecutive VPCs, okay, more than 3 consecutive VPCs, and that lasts for less than, and that whole VT starts for less than 30 seconds, it is called a non-sustained VT. If it lasts for more than 3 VPCs occurring together and they last for more than 30 seconds, regular broad QRS tachycardia, it is sustained VT. Okay, so they're all regular broad QRS, but if they're less than 30 seconds, it is ill sustained VT. If it's more than 30 seconds, it is sustained VT. Okay. So how do you treat polymorphic? If the patient has polymorphic VT, what do you do? How do you treat it? How do you manage?
Synchronized cardioversion we can do. He's in hypotension.
magnesium.
Polymorphic VT.
Magnesium.
Magnesium, correct. Antiarrhythmic agents will use.
You use synchronized, non-synchronized.
In polymorphic, non-synchronized will use.
Yeah, so why are you saying synchronized? Don't say synchronized, no?
Yes. In polymorphic, non-synchronized.
So it's like VF only. So it's
Yes.
like a VF. It's like a VT with pulse. Okay. Anything else, Dr. Madhusudan?
Yes, the patient is going for CABG. Patient underwent for CABG and came back to you again. What are the critical care principles we follow for the post-operative patient? Important factor, we are not discussed one more important factor.
Post-operatively, we try to maintain the hemodynamics, sir, first. Second thing, we would try to maintain the coagulation also, sir.
Okay.
Why coagulation? They have no coagulation problems after surgery. Why will they have coagulation problems?
Patient went on pump, then they're given any coagulation.
No, they will not have it. They'll reverse it before they
Just monitor the coagulation parameters.
No.
After that, pain management will take care of it. No?
Drains, tubes.
Okay. Drains, tubes, the basic principle about your nutrition, more important about the sugar control, the insulin infusion for the patient, what we are giving feeding for them, and important about the drains. Okay, when we call for the surgeon about the drains,
Drains more than 100 ml per hour, we call them.
200 ml per hour or 400 ml in 4 hours or more than a half liter in 5 hours, then we have to.
no, you have to tell properly. There is an indication for re-exploration. What is the indication for re-exploration of post-op CABG patients? 400 ml of the blood loss through the ICD or the drain. It may not be ICD, it may be the drain, pericardial drain or the pleural drain.
The 2 hours.
Actually, it is 400 ml per hour or the 300 ml in 2 hours or 100 ml per hour. These are the all indications for the re-exploration for the patient of post-operative CABG. What is Shoemaker criteria?
No idea.
Heard about Shoemaker criteria?
No, sir.
You have to read it. Okay, it's important about thing. Now, this post-operative, the CABG patients, as patient had ill-sustained VT, and the ill-sustained VT is there for the patient going for the CPR. For what are the patients we are going for? How we will do CPR for this patient for post-operative CABG patient? Patient having sternal wires, patient having a pacemaker wires. So Venkat also put one question about drugs which has shown the mortality benefit. After this, we'll take this question also. What is the difference between CPR of a post-operative CABG patient?
Of joules which will be going to deliver will be lesser actually.
No, before that we have to do chest compression. Na?
Yes.
Defibrillation come afterwards. Take the help of the surgeons, open the sternal wires, and we can do an internal cardiac massage. Okay, that is the difference is there about the post-operative CABG patients. That's the reason if you see in the post-operative, they always keep the cutter beside the patient so that any event happen for the patient, we can immediately remove the wires and we can do CABG for the patients. Okay, we can do immediately CPR for the patient, cardiac massage. Okay, other just now Venkat asked the question about which are the drugs which have shown the mortality benefit.
Beta blockers.
ACE inhibitors and spironolactone, statins.
What are the other drugs? You told about beta blockers, ACE inhibitors, other drugs which are shown the mortality benefit, and particularly for the ACS. Because whenever we do any procedures or interventions are there, what is having advantage and what is the morbidity or mortality benefit is more important for the patient. On that basis, we use the medications or we do that particular procedure. That's what we discussed about whether thrombolysis versus PCI for the patient. In the same way for the medications also. So that any patients having a negative inotropic action, we avoid in cases of the patient having an cardiogenic shock or the patient having a moderate to severe dysfunction is there. Okay, I think already we reached to 8:45.
Dr. Venkatramana has any questions to ask? He can ask. Dr. Venkatramana?
Ma'am, I think a very extensively discussed topic. I think most of the areas you both tried to cover, and we had almost more than 200 participants joining across for almost 1.5 hours. So very well actually discussed, elaborated. So one of the situations which has thrown to the students is after a CABG, after a PTCA, primary or elective PTCA, these patients come to the ICU and suddenly you see a dynamic ECG changes. So what are the common suspicions which should go to you?
Post CABG, sir.
Post CABG, post PTCA, you have a dynamic ST changes.
Restenosis, stent collapse or restenosis.
And thrombosis.
Giveaway of the
Stent.
Partly we discussed this one, not completely.
Stenosis or stent thrombosis?
Stent thrombosis, sir.
So stent thrombosis and graft thrombosis or graft occlusion will be the most common possibility which need to be considered. And how do we actually approach them?
Sir, again, we have to reopen, sir.
So for a CABG, it may need a re-exploration, or
Yes.
for a PTCA, what do they do?
Take up for CABG. Sir.
No.
No.
No. You will not take for CABG. Why CABG?
They will
They'll
again
die immediately on the tape. I don't know they'll die if you take up for CABG. You have to take them back to the cath lab.
Cath lab.
They
Like
take
post-
back to the cath lab. They try to open the vessel, do a thrombosuction, and try to open the vessel again, because it will be like a again you will see the ST dynamic changes, and you will have a further cardiac deterioration at that point of time. And it's not very uncommon. We see
Yeah.
acute cardiac decompensation in your post cath setups or a post CABG setups. So how do we actually, if suppose the patient post CABG a couple of weeks down the line or a week down the line in your hospital suddenly developed this, how can you diagnose them that there is a graft thrombus?
Sir, again, we have to go ahead with 2D echo and troponin markers, sir.
How do you know that there is a graft thrombus? You will not know.
Angiographic evidence.
So what in patients in graft thrombus in acute probably post CABG setups in a post-operative ward with the dynamic ECG changes and the cardiac decompensation, they may need to take off into the cardiac OT. So there are situations from cath lab to OT which we call as nowadays hybrid cath labs or hybrid OTs, where you convert the cath lab to OT, convert the OT to cath lab, where you can do an angio and cath lab, and then the same area can be converted into a OT in setup of taking the patients into a CABG situation. So there are also areas of both, ma'am, beating heart and on pump CABGs
yeah.
nowadays. So that's an area where there are a lot of discussions. And what are the other complications of acute massive myocardial infarction other than whatever you have said, cardiogenic shock? What are the other catastrophic complications which can happen in some situations?
Hemorrhagic shock can happen, sir.
I'm talking about MI causing a catastrophic complications. Why hemorrhagic shock?
Because of the rupture also it can happen, sir.
So free wall
rupture, cardiac tamponade.
Cardiac tamponade. Anything else?
Arrhythmias, hypovolemic shock also can be seen in this
We
patient.
discussed now
I
VSD.
think all that you
VSD,
discussed.
papillary muscle rupture.
So free wall rupture, papillary muscle rupture, and maybe
Acute
probably
MR.
valvular. We see some mitral valve giving up on the situation. So sometimes if they are been given up very badly, you may need both CABG and valvular repair simultaneously in those situations. And you mentioned about the drugs which are shown to be mortality benefit in this peri-myocardial infarction or peri-CABG, beta blockers, yes. And then you said SC inhibitors in some of those remodeling situations. Not statin. Statins has never been seen to improve the mortality.
The mortality, yeah.
Spironolactone, yes. Spironolactone has also been contributed to see some the kind of benefits in them. So the most important point, probably from my point of view, I will tell ki most of our critical care clinicians, students, DNBs, or our ISCCM students may not be actively involved in many ICCUs. So they will be more predominantly looking at the medical ICUs. They may be rotationally posting sometimes, or sometimes they just see the cases on theoretical basis. So I request these are the cases which sometimes you get trapped when you directly get these cases in the exam. So I request all the students to keep a close follow-up and or rotation on all these ICCU cases, cardiac cases, so that you will have a 360-degree angle on your training. So I think most of the areas are covered, ma'am. Any other questions which are left in question answer session?
Sir, I wanted to know about GP2B, sir.
So they are all into the heart failures. So I'm not sure whether
no, GP2B3A is actually there's no recommendation actually. Only
No.
during PCI. During PCI they can give it.
Okay, GL2, GP3A, that is I would like, okay.
Actually, whenever the thrombus load is more for the people, those who have done the angio, particularly for the people, such young people, smoker, alcoholic, they do some intervention for the patient, and then they'll continue for glycoprotein 2b3 inhibitors infusion for a period of 8 hours, 12 hours. That is the role is there only.
Okay.
And a role in non-ST elevated MI or most of the times when they try to use. I'm actually talking about that Sartans, Vimeda, that group of drugs,
Sacubitril valsartan.
which again show to be a
Sacubitril.
mortality benefit and hospital free days. I'm actually overlapping with our diabetic
Failure, sir.
GL4.
It is basically for the heart failure patients.
Heart failures.
And what just now Venkat told, once we do PCI also, after that, the dynamic changes in the ECG almost come down 50% within 4 hours. If it's
Yeah.
not coming down within 4 hours, then you have to think about all these things are there, then require other intervention for the patients.
Okay, sir.
Ma'am, any comments, final comments so that we can wind up?
No, I think the oral management is important. You have to closely monitor these patients post-MI, especially regard to the bowel care, regard to the exertion, monitoring for the arrhythmias. Okay, and both body and so make it a point to see the ECGs on a daily basis to see what are the changes that are occurring, because subtle changes you may miss on the ECGs. So we have a look at that, and then each drug, see the contraindication indications, whether the person is what the benefit is getting from the drug, and then give it accordingly. So I think you have to just closely go through. I think only thing about tachyarrhythmias is go in detail about read about the ventricular arrhythmias. You're not very sure about how to manage ventricular arrhythmias, monomorphic, polymorphic, and what are the causes of each of these? What are the errors which have to be corrected? Okay, so VT, VF you have to read. That's very important because they as part of the ACLS also. Otherwise, also you need to know about the VT, VF management in the patient. Okay, more than bradyarrhythmias, they'll get to give you some time. Tachyarrhythmias won't give you time, so you have to be very up to date with the tachyarrhythmia management in post-MI situation or otherwise also. Okay,
So
I think Madhusudan.
Nothing. All other comorbid conditions has to be taken care for the patient along with PCI and interactions of the medications you have to understand. When you are using the antibiotics, the macrolides and other medications which are there, which causes a QT prolongation, that you have to keep in the mind. And important part is about we're forgetting about the sugar control. Always make it a point for acute MI or perioperative patients are there, sugar has to be controlled properly. And the basic critical care, we should not forget about giving nutrition, keeping watch, infection control, electrolytes, all these things are very important.
Bowels also. So
Yes,
they should not
bowels.
stain at stool and post.
This, I think we thank both Dr. Chandana ma'am and Dr. Madhusudan for actually coming forward and rescuing in this session. And they took
Rescue
care of
PCI. Rescue PCI.
so because Umendra Singh had some personal reasons, so he could not join. So both of them helped our students, and probably there were almost 200 plus students of postgraduates who benefited by this session. And what an extensive discussion happened. It's from length and breadth to both the sides. And thanks both to Karthik and Vignesh in bringing this case. We thank all the participants for the questions and enthusiasm. With this, we conclude the session. Thank you all.
Thank you.
Thank you.
Thank you. Thank you, sir.
All the best for you.